my friend and colleague Leonardo Raiella, who's a leader in the field of transplant. He's the medical director of the kidney pancreas program at the Mass General. He will be talking about late post-transplant medical complication, but also another talk about xenotransplantation. He will be our keynote speaker for the day, and to give us update from the first experience with xenotransplantation from his program. Leo, please.
Thank you, Jamil. Appreciate for the invitation again to be joining you remotely here. And so I'll ask maybe for the organizers to upload my first set of slides. And we'll start by, I would say, one of the most important topics, I think, for the general nephrologists and transplant nephrologists, which is, the long-term management of kidney disease, kidney transplantation in particular, and we'll be speaking about these late post-transplant medical complications. I'll tell you why this is such an important topic is that, as we grow, as we start doing more kidney transplants, the kidney transplant programs cannot accommodate all the patients that are transplanted in individual centers. So we're going to be depending on our referring nephrologists to take over some of the care of these patients. And so the objectives of the next 30 minutes is to recognize what are some of these major late complications after kidney transplant and choose some evidence-based management strategies that might be slightly unique or different in transplant compared to general kidney disease, and then identified some of the transplant-specific board pearls that are relevant for those that are taking the board. With those concepts in mind, let's start with our first case. So this is a 45-year-old male who had a living donor kidney transplant 3 years before, had a stable creatinine around 1.5. And the question is, for this patient, what is the most likely cause of death with a functioning graft? Is it malignancy, A, B, infection, C, stroke, D, cardiovascular disease, and E, trauma? Remembering that dying with a functioning graft is actually one of the most common causes of graft failure, and so we do need to know how to prioritize some of the risk factors. And I see answers are coming in. I'll give you another few seconds. Awesome. So most of you got it right. The most common cause of death after kidney transplant is cardiovascular disease. And so we're going to go over now, I think, a few of the important points relevant to late post-transplant medical complications, including heart disease and diabetes. We'll cover some cancer, which is also a second leading cause of death, and then we'll discuss a little bit about recurrence of kidney disease, since this is also relevant in particular for the board. Let's start with our cardiovascular disease. So this is how, if we look at all kidney transplant patients that have been performed in the US and look at causes of death with a functioning graft, cardiovascular disease tends to be the leading one, in particular because many of our patients are diabetic. A big portion of it are diabetic, followed by infection and malignancy. If you get and remove all the diabetic patients, you would see that malignancy and infection becomes dominant causes, followed by cardiovascular disease. What is interesting about cardiovascular disease in patients with kidney disease is that there's sort of an advanced aging that occurs in terms of the prevalence of these mortalities. So what you see here on the top, let me make sure I get you my laser here. What you see here on the top is the rate of cardiovascular mortality let's start on the bottom, in the general population. As you get older, your risk of cardiovascular mortality rises, but if you see the younger patients, they had significant lower risk. If you get started on dialysis, if you have end-stage kidney disease, you can see how there's a huge rise in terms of the the prevalence of cardiovascular mortality in this population that continues to increase over time. And when you get a kidney transplant, you sort of correct in part that higher risk of cardiovascular mortality. Many of our patients will not go back to the general population because of the multiple years that they may have had kidney disease and some cardiovascular complications. But this is the importance about transplanting our patients early so that you can minimize some of the damage that occurs on kidney disease, in particular in the cardiovascular system. And we can think about those traditional risk factors such as hypertension, hyperlipidemia, hyperglycemia, and diabetes, as well as smoking in advanced age. But in the case of transplantation, there's also some unique factors which scale up those complications. So immunosuppressive drugs can impact many of these metabolic risk factors of cardiovascular disease. On top of that, I think what's very relevant is that if you have a poor functioning graft, that is contributing to your cardiovascular disease. Also, the time that you've been on dialysis prior to receiving a transplant, as well as the cumulative risk that occurs with bone mineral disorder. So if we just use the isolated risk factors that we know of cardiovascular disease in the general population, we miss all these additional risk factors that are critical in order for us to try to build that risk calculator for individual patients. Among things that are important that I think many times we don't think about is one of them is vascular calcification. So this is a study that recently came out, and it looked actually at coronary artery calcium scores and all-cause mortality. So we're not talking about patients that have a significant stenosis that may be more prone for cardiovascular mortality. We're talking about just those calcifications that happens in the media. What it shows here is that the amount of calcification in the blood vessels correlates directly with their cause of mortality. So next time you're looking at abdominal CT, you're looking at chest CT, look for the amount of calcifications that you see on the blood vessels, because they can clearly tell you about the risk factor or the magnification of risk for a patient with cardiovascular disease. So immune suppression may have different effects in terms of cardiovascular risk. For example, tacrolimus is one of the key immune suppressive drugs in the maintenance regimens that we use. And we know that they inhibit insulin secretion and have a rate of diabetes that ended up being almost 25% of the first year after transplant for those that are non-diabetics. They can also contribute to hypertension, but cyclosporin, our older generation calcineurin inhibitors, tend to be slightly more pro hypertension. And then we have some other immune suppressive drugs that have unique side effects. For example, the mTOR inhibitor tends to cause more hyperlipidemia, and steroids tend to influence many of these risk factors, including diabetes, including hyperlipidemia, including hypertension. Let's move on to the second case, which is still under that umbrella of cardiovascular disease and metabolic complications, but he's a 58-year-old male, 3 months post-transplant, with a fasting blood glucose of 145 and a hemoglobin A1C of 6.9. He's on triple immune suppression, tacrolimus, mycophenolate, and prednisone. And the question is, what is the primary cause of post-transplant hyperglycemia in this case? Is it glucocorticoid-induced insulin resistance? Is it hepatic insulin resistance via interleukin-2? Is it calcineurin inhibitor-induced beta cell dysfunction, SGLT2 upregulation, or CMV trigger insulitis? And I'll give you a few seconds to pick the right answer. And most of you picked the right one, which is C, which is tacrolimus impairs beta cell function leading to post-transplant diabetes. And this is an important thing because, you think about diabetes as being, ultimately the outcome that you're going to be measuring. But many of our patients, if we perform a glucose intolerance test, they actually may present with significant hyperglycemia after those tests. So you have sort of a spectrum. You have those that have no diabetes and no glucose intolerance. You have a big portion of these patients, close to 57% or close to 22%, that have what we call prediabetes, some glucose intolerance, and then the rest, about half of our patients who do not have any glucose intolerance. And why is this relevant? Because even the pre-diabetic state is associated with a significant higher risk of both mortality and graft failure. So again, we are trying to risk stratify our patients in trying to identify those at increased risk. This is just schematically kind of looking why our patients develop hyperglycemia post-transplant. You have the calcineurin inhibitors inhibiting insulin secretion. We also have many of our patients who gain weight after transplant, so they can become more resistant to insulin, both because of adipose tissue and skeletal muscle, and they may also see an increase in hepatic gluconeogenesis. And all these three main factors could contribute to these transplant-associated hyperglycemia. I think one of the crucial aspects about diagnosing that is that, unfortunately, either you do your fasting glucose, ideally you do a glucose tolerance, but hemoglobin A1C, particularly in the early few months after transplant, is not very reliable. So we have to have a low index of suspicion to look for glucose intolerance in our population. I think images can tell you so much about, and I love this experiment where they incubated beta cell islets with either a control molecule, cyclosporin, or tacrolimus, and then they measure the amount of insulin being secreted by these beta cell islets. And what you can clearly see compared to control, how tacrolimus significantly inhibits insulin secretion. And that's why many of our patients become diabetic after transplantation. The other aspect that's interesting is about steroid withdrawal. So there has been a push, in the past 10 years or so to try to get most patients off steroids, in particular those with low immunological risk. This is probably one of the best randomized studies that have been assessed at, because they compare also two different types of induction therapy. They compare basiliximab with rabbit ATG, which is the T-cell depleting agent, and then they also compare patients that were on steroids and those that were not. And what you can clearly see from this picture is that at 12 months, and this, they did perform a glucose tolerance test in order to diagnose diabetes, but you can see that the incidence of diabetes in patients who were on steroids was close to 40% compared to those that were not. There was around 22-23%. So steroids, even in low doses as we currently use in most of our transplant management or immune suppression protocols, they still can contribute to post-transplant diabetes. How do we manage this post-transplant diabetes? Like a usual patient that you may see in your nephrology clinic, we always want to think about diet, exercise, weight loss, with the goal of getting your hemoglobin A1C below 7.5. It is also relevant when we're talking about transplant recipients to think about, is there any adjustment in immune suppression that we could perform? In particular, reducing calcineurin inhibitors, and if it's a patient who we know it's going to be prone for developing diabetes, potentially get them steroid withdrawal if they don't have a high immunological risk. The second set of agents to be considered include metformin as an oral hypoglycemic agents, SGLT2 inhibitors, glycosides, and lately, in particular, if the patient is overweight, GLP-1 receptor agonists. And of course, if they're still refractory, if their blood sugars are still high, we should definitely consider insulin therapy. It will be very exciting to be using those continuous glucose monitoring in our patients, so I think they can provide a very interesting insight and potentially diagnose even earlier some of these glucose intolerance tests, because many of the transplant centers and hospitals do not perform glucose tolerance outside of the research environment, so that limits a lot for us to identify this pre-diabetic group of patients. We performed this large meta-analysis and systemic review looking at 32 different studies, over 7,000 patients, kidney transplant recipients that use either SGLT2 or GLP-1 receptor agonists. And the idea here was to see, was there, number one, any safety signal, anything that would make us worry about using these drugs in the post-transplant scenario, because we clearly know that they have a huge benefit in kidney disease patients in general. And second, what were some of the benefits that these studies, observed? And so it's a large subset here that we're accounting for. As you can see here on the right side, it sort of summarizes some of the key things. So SGLT2 inhibitors was associated with improvement in magnesium. So this is sort of an unexpected effect of SGLT2, which is positive for kidney transplant patients that tend to waste magnesium, reduced serum levels of uric acid, and no increased risk of urinary tract infections, which was always a major concern. For GLP-1 receptor agonists, there was no increased risk of pancreatitis, and both drugs showed a huge benefit both in hemoglobin A1C reduction, weight loss, reduced mortality, and improved cardiovascular and kidney outcomes. So I think we are moving towards using these drugs more often, in particular once patients are stable on their maintenance immune suppression regimens after 6 months to 12 months. This is how we have been using at MGH. So we look at patients after 6 months, if they have a GFR above 30, stable immune suppression, no recurring urinary tract infections, and we consider adding the SGLT2 inhibitors. We monitor blood pressure, creatinine, and GFR at 2, 4, 6 weeks after initiation. If they're going to go through a procedure, we tend to hold these drugs 3-4 days before the procedure. And for patients that have a GFR below 30, we may consider GLP-1 receptor agonists instead. The drugs that are available, including empagliflozin and canagliflozin, they're sort of easy to use. There's a standard dose that is used in the majority of cases, so not much up titration there needed. From this metabolic and cardiovascular, let's shift gears to case 3. So this is a 75-year-old, 20 years post-transplant, about 20-pound weight loss and night sweats since his last visit. On exam, he has a palpable allograft on the right lower quadrant and enlarged lymph nodes. And the question here, what's the best next step to work up this patient? Do you perform a kidney biopsy? Do you do a PET-CT? Do you do a chest x-ray, abdominal x-ray, or an abdominal MRI? I'll give you a few seconds. Great. So I think the answers have been mostly between B, the PET-CT, and the abdominal MRI. So in a case like this where there's significant weight loss, night sweats, very late after transplantation, malignancy does become, one of the leading diagnoses here. So a PET scan can really help you elucidate where is this glucose uptake, where are these highly metabolic areas in the body, and can we get a biopsy? And so in this case, as you can clearly see, you see all this uptake here on the right lower quadrant, and some of it is their lymph nodes. So these are easy spots for us to go with a needle and get a specimen of these lymph nodes in order for us to be able to diagnose what's happening here. So we're moving on to this category of cancer, and there are a few cancers that have a significantly higher risk after transplantation. So those are post-transplant lymphoproliferative disorder, or PTLD, that in many cases associated with Epstein-Barr virus, skin cancer, that it's close to 40 to 50 times more common in patients who got a kidney transplant compared to regular patients. As you can see here, these lesions tend to appear mostly in exposed sun areas. We have other cancers that can be associated with other viruses like HHV8, like Kaposi sarcoma, which can involve both skin and internal organs, and a higher risk of kidney cancer that mostly develops in the native kidneys. So these are the 4 most common cancers that we see post-transplantation. Why is cancer so common after transplant? It's a combination of factors. I think number one, for example, with the skin, sun can cause damage to the DNA, and we need our own immune system to sort of, do some of the DNA repair. And when you're using immune suppressive drugs, you are impairing this DNA repair. We're also transplanting older patients, and older patients have less of a capability of correcting this DNA repair. In addition, many of the viruses that you can have an infection post-transplant, or opportunistic viruses, they can be oncogenic viruses, meaning that they produce growth factors and anti-apoptotic proteins that can promote the proliferation of tumor cells. And last of all, because these patients are all taking immune suppressive drugs, they're weakening the immune system, and the immune system is a critical player in what we call immune surveillance. So just scanning your cells and ensuring that you destroy any cell that may be proliferating out of control. And with that inhibition, some cancers are more predisposed in developing malignancy after transplantation. These are the three pockets: DNA damage, immune surveillance, and oncogenic viral infections, the three reasons why cancer is so common after transplant. PTLD is a hematologic malignancy. Non-Hodgkin's lymphoma is the most common type of PTLD. What's unique about it is that it can peak on the first year after transplant, but then it can happen also later. The early ones tend to be associated with Epstein-Barr virus. So you have a patient who potentially were never exposed to Epstein-Barr virus. They get an organ that has Epstein-Barr virus, and they ended up developing a viremia that tends to cause B cells to proliferate out of control. There's some other risk factors, such as those that receive high degrees of immune suppression, or they had a co-infection with cytomegalovirus. And the treatment is very unique, compared to some of the other malignancies, because reduction of immune suppression is one of the cornerstone treatments of PTLD. So you have to reduce your immune suppression, and then depending on the severity of the PTLD, you may add on CD20 B cell depletion therapy, as well as chemotherapy, what we call the R-CHOP. Treatment, if you detect early, tends to be good, so you tend to be able to treat these cancers, but of course it's something that if we monitor EBV early on, you may detect earlier. You can even consider giving rituximab in addition to immune suppression reduction before you develop PTLD in patients who have persistent EB viremia early post-transplantation. Among all the immune suppressive drugs, there's only one immune suppressive drug that have shown a reduced rate of skin cancer recurrence in kidney transplantation, and that's the mTOR inhibitors. mTOR inhibitors, rapamycin, everolimus, is a major immune suppressive drug that can be used in place of tacrolimus, in place of the calcineurin inhibitors. And this was a study that was published now a little over 13 years ago in the New England Journal of Medicine, that they randomized patients, kidney transplant recipients that develop one skin cancer, to either continue the same therapy or switching from a CNI to an mTOR inhibitor. And they looked at the survival free of squamous cell cancer at 2 years, and they could see a significant reduction, relative risk, about 44% reduction rate of skin cancers when you do the conversion to the mTOR inhibitor. The challenge with the mTOR inhibitor is mostly related to the side effect profile. 1 in every 4 patients will not tolerate mTOR inhibitor. And we also know that in addition to side effects, this medication is associated with less immune suppressive effect. So patients who get converted to mTOR inhibitor tend to develop more donor-specific antibodies, more often developed a chronic antibody-mediated rejection. So you have the cancer benefit, but it comes with a cost, so you have to individualize the decision. So what's the immunological risk of this patient, and would they benefit from an mTOR inhibitor conversion or not? Talking about malignancy and now more metastatic disease, let's talk about this kidney transplant recipient in case 4 who has advanced squamous cell cancer and is now being considered for a salvage therapy with immune checkpoint inhibitors. So what's correct or most accurate about immune checkpoint inhibitors post-transplantation? It is contraindicated in all cases. B, 40% risk of rejection with ICI use after transplant. It's safe without immune suppression change. It can lead to rejection, but it's not a concern if the patient is EBV negative, or it should be considered combining with CNI to reduce tumor growth. And I'll give you a few seconds to tackle this answer. And most of you selected B, 40% risk of rejection with immune checkpoint inhibitors. And that's right. So there's a very high risk of rejection. And so we use it, in selected cases. And our patients tend to be very worried about any treatment that may impact their transplant and cause them to go back to rejection. So this is the study that we conducted at the Brigham. One of my trainees, Murakami, was the lead author here, and she looked at a retrospective cohort from 2010 to 2020, where 23 international centers, 69 transplant recipients that receive either anti-PD-1, anti-PD-L1, or anti-CTLA-4. And we looked at, what happened within that first year after treatment, and you can see the high rate of rejection of 42%. The rejection happened early. Within 3 or 4 weeks, these patients were developing a rejection. And what was tough is that many of these patients who developed rejection, close to 65%, ended up having graft loss. The tumor response, both complete and partial response, was close to 36% in squamous cell and 40% in melanoma, which is actually quite good for the prognosis of some of these cancers. But unfortunately, we are sort of stuck with this high rejection rate in transplant. So what can we do, and what have we learned so far? So one of the strategies that we have been trying to deploy in patients who need to get immune checkpoint inhibitors because of advanced cancer is to cycle mini pulses of steroids whenever they get this immune checkpoint inhibitors. And we also consider the transition from the tacrolimus to the mTOR inhibitor. And this is an example of these mini pulses of 5 days of prednisone 40, another 3 days of 20, and down to 10 until you repeat the cycle. And we actually conducted a study on this. There were 12 patients that were treated with anti-PD-1 for advanced squamous cell, and by using this mini pulse steroid protocol, we were able to get a very good response, 45%, and no evidence of rejection. We have treated personally other patients outside of trial. In some cases, we do see some rejection, but I think we've been able to minimize the rate of allograft loss. So instead of being too aggressive in reducing all anti-rejection meds, I think we got to be a little more cautious when we're using the immune checkpoint inhibitors. So it can be used, but it has to be used in a very moderate fashion. And this is one strategy that we are deploying in our center. So a question that always comes up that's clinically relevant is, what do we do with immune suppression whenever a patient develops a cancer? I think that the first learning point is never fully stop immune suppression, okay? And the reason is that there's some cancers that are more sensitive to immune suppression, while others are not. For example, breast cancer and prostate cancer are not immune suppression sensitive. So if they develop a cancer, we don't need to be aggressive in reducing immune suppression. However, if you're treating someone with cytotoxic therapy, you're going to have to do some adjustments in order not to increase the risk of over-immune suppression. And mTOR inhibitors in particular, I think, are beneficial in specific scenarios. I think the 3 cancers in which this conversion should be considered is squamous cell cancer, in particular when it's recurrent, Kaposi sarcoma, as well as kidney cancer. So this is just to give you an idea of some of these unique aspects of patients who develop cancer, and we have to make decisions about what to do with their immune suppression. And finally, on case 5, we'll talk about disease recurrence. Then the question is, which best predicts recurrence of membranous nephropathy after transplant? The amount of proteinuria pre-transplant, the time on dialysis pre-transplant, the level of anti-PLA2R antibody above 150 pre-transplant, HLA, DR mismatches, or the presence of donor-specific antibody prior to transplant. And I'll wait another 5 seconds for you guys to pick the answer. And most of you are selecting C. And the answer is correct. So what we've learned is that testing for anti-PLA2R antibody, and in particular if they're high levels, they have a really high correlation. And if you think about recurrence of glomerular disease is the third leading cause of graft loss, and each glomerular disease may have a different dynamic after transplant. Some diseases recur very early, some may take about a year or two, and some may take years to recur and cause disease. And so this is an example of an early one, which is systemic FSGS, and a really late one, which could be either IgA or membranous nephropathy. And this is the study that I think really changed the way we think about it. It was conducted by our Tango consortium that looks at glomerular disease recurrence, and we saw an incidence of recurrence about 30% at 10 years. But most importantly, is that the outcomes of these patients with membranous recurrence were actually, overall very good, in particular if they underwent either partial or complete remission. I think what changed the management of membranous recurrence has been the use of rituximab. So for patients who use rituximab early, those had the best benefit of all patients that we monitored post-transplantation. But if we look at anti-PLA2R antibodies at the time of transplant, there was a hazard ratio of 18 for those that had antibody positive compared to those that did not at the time of transplant. So it's highly associated with recurrence. Do we need to freeze or delay a transplant because of these antibodies? And the short answer is no, because membranous nephropathy takes months to years to develop. So I think we have to take our patients off dialysis as soon as possible, get them transplanted. But we do see that patients that have a higher levels of anti-PLA antibody going to transplant, in particular if their level is above 150, their rate of recurrence within the first year after transplant is extremely high. So these are patients that we are considering giving them some B-cell depletion with rituximab to minimize these recurrence risks. So what are the take-home messages I wanted to have out of this is that cardiovascular disease is the leading cause of death. So, having a functioning graft is not enough. We have to be looking at all these risk factors and trying to control them as much as we can. Think about tacrolimus as one of the key players driving diabetes rate after transplant. Cancer post-transplantation can be associated both with viral infection and overimmune suppression. Don't stop all immune suppressive drugs, but try to do individualized decision based on immunological risk and the type of cancer. Immune checkpoint inhibitors can lead to up to 40% of kidney rejections, but there are strategies that we can potentially deploy to minimize that. And think about recurrence of disease and think about potential biomarkers that we can use to predict that and early intervene, and we make the case about anti-PLA2R antibody. So these are some of the references that I put it out there, and some summary of the clinical trials that we won't have time to go through.